Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Apnea. A few weeks ago, we received an email asking us to explore the reliability of the residual AHI on PAP downloads. Since we make clinical decisions based on this metric, it is important to understand not only the mechanistic components of how this is determined, but also to be able to compare it to an AHI during a polysomnography or home sleep apnea test. Is this a metric we can trust? Are there differences in how this is determined from brand to brand and from one iteration to the next? What other information can we obtain from a download that may impact the way we treat patients? Dr. Robert Thomas has written about this previously, and Dr. Imran Iftikhar, Dr. Tavi Uakimescu, and their colleagues performed a meta-analysis of the data and published it. Dr. Robert Thomas is a professor of medicine at Harvard Medical School and in the Division of Pulmonary, Critical Care, and Sleep Medicine at the Beth Israel Deaconess Medical Center. Dr. Iftikhar is an associate professor of medicine at Emory University in Atlanta and practices sleep medicine at the Atlanta Veterans Affairs Medical Center. Dr. Tavi Uakimescu is a sleep medicine physician with the Medical College of Wisconsin and the Milwaukee VA. They are here to share what they learned about the accuracy and reliability of the residual AHI on PAP downloads. Thanks for joining us today.
Thanks for inviting us.
Happy to be here.
Thank you for having me.
So, Dr. Thomas, let's start with you. You published on this topic a few years ago, and in your paper, you discussed stable sleep versus unstable sleep. What does this mean?
So when we look at the waveforms, and the stable-unstable domain can be is visible only on the waveforms, not by the metrics extracted.
So you mean that detailed?
Even the details. The detail again just gives a numeric rather than the actual waveforms. However, these days, the ResMed ASV does provide some sense of a waveform. But the Philips devices gave waveforms certainly by about 2012 when I started using Philips. And the waveforms are available for all their devices online. Now, you can see the waveforms by using freeware like, Sleepyhead in the past and now OSCAR. And the ResMed also has software which allows you to see the waveforms, but it's very tedious. You have to, extract it on an SD card and put it in your computer and have the ResScan software, and it just takes up too much time. But when you look at the data, when breathing looks boring, for want of a better term, where the breaths are just similar to each other and they just go on and on, every line of respiratory fluctuations looks like the other. That's pretty much stable breathing. And on PSGs or home sleep apnea testing, when we look at the data, there are clearly periods where nothing much is happening. There may be some snoring perhaps, but nothing much else is happening. There are no apneas, hypopneas, arousals, DSATs, nothing is happening. And then there are periods where things are happening. And this sort of bimodal nature of sleep is distinctly seen, especially in non-REM sleep. And it's just part of the natural biology of non-REM sleep. And it cuts across various stages. So N1 is virtually always unstable. N2 can be stable or unstable. N3 is normally stable. So the stability domain goes across these various conventional stages. And regardless of what we think we're doing, when we're trying to treat patients, we are actually enabling stable state.
So what makes you decide to then look at those details? Is it because there is an elevated AHI, or is it just something you do for every patient?
I try to do it for every patient. It's harder now with the ResMed devices and televisits. Patients who come to clinic, they bring their SD cards along or they bring their machines along. But for the televisits, it's a headache. They mail me the cards and such. There is this system called SleepHQ where patients can upload their data and such. I'm just worried about confidentiality issues when engaging with that. I don't think my hospital would like me to engage with that. So we have a mailing system. They mail it to me, and I have a little box where I dump these SD cards and view it and then get back to the patient. So it's more tedious. But when they come to clinic, it's much easier. Philips, you see it online. A few years ago, they stopped their, well, I guess with the recall and such, they stopped the Wi-Fi version of their data where you could get nightly waveforms. It was almost too much data. Otherwise, these days, you get every 2 weeks, you get 2 nights of detailed data where you can see the entire use tidal volume fluctuations.
So that does sound pretty time-intensive, labor-intensive to do that.
Yeah, so if you're dealing with patients who are fairly straightforward, doing well, not sleepy, the machine estimated AHI is low single digits, you don't have to chase it.
Okay.
But if you have, if it's not going that well, whether the AHI is high single digits or even higher, and the patient is still feeling tired, etc., a quick glance at the raw data actually is very useful. Doesn't take much time. The main time is kind of moving the card around or logging into the system. The actual visualization is actually quite simple.
So I heard you say OSCAR and I heard you say SleepHQ. Can you tell us about these programs?
So OSCAR is a freeware which allows you to sort of hack into the SD card data from Philips and ResMed, Fisher-Paykel too. I don't believe right now it can view the Luna devices. I don't think so. And it's a data viewer. So you see the breathing, but you also see things like inspiratory time, expiratory time. The PAP devices do compute quite a lot of information. Like its functioning requires it to compute quite a bit of respiratory information. It shows much less, and it uploads probably even less. So you can see that kind of detailed data, but it does not generate new numbers. So what it shows you in terms of the numbers are kind of what you see on the app or in the device reports. But you can see with your eyes whether it's stable breathing or unstable breathing, post-arousal centrals. And the problem with the, I'm sure we'll come to this, but one of the problems with the automated estimation is that it's very rigid rule-based. So if the patient has slightly longer events or short events, or has a slow rate of change of respiratory abnormality, it simply won't pick it up. So at the higher end, if your machine detected AHI, say 20, you really don't need to look at waveforms. It's going to be clearly abnormal. But the low single digits, that's where it's most useful to view the waveforms. And SleepHQ. SleepHQ is essentially an online system where patients can dump their data and send you links to look at it, basically.
So that's interesting.
And you pay a little bit for it.
Oh, you do? Okay.
I'm sure you do have to pay too. Yeah.
So you said, so what I heard is it's the same, like they look at the waveforms, all that information is already there in the PAP device, and the calculated AHI is similar or the same with OSCAR and SleepHQ, right? And so the benefit is being able to look at the waveforms then.
Correct. If they generate new data, then it becomes literally a medical software. Like, it'll need FDA clearance and so on.
Oh,
but
that makes
a
sense.
viewer is, you can't really complain about a viewer. It's just showing the data which is already there.
So then, do you think the residual AHI that we look at on a PAP download, do you think it's reasonably accurate? Or do you feel like it overestimates or underestimates events?
It's usually an underestimate. But if it's clearly high, it flags the problem. I mean, that's ultimately what you're looking for. I don't care whether the actual AHI is 22 or 32. It's too high. But there are some situations where it will overestimate. One example is opiates. It slows down your breathing enough that the device may start picking up central apneas just because you have long expiratory durations. And if there's substantial wake mixed up in sleep, the fluctuations of breathing, when you're transitioning between sleep and wake, or when you're awake and thinking or reading or even chewing and so on, can be picked up as abnormalities. But short of those two situations, usually it's an underestimate. And short cycles of respiratory abnormality what I call high loop gain apnea, where the breathing looks like high altitude, short cycle non-REM fluctuations is missed entirely. Long cycle events are picked up actually quite accurately. So when the fluctuations in breathing fit the algorithm of the device, it works really quite well. But patients are just variable enough that in the mid-low single digits, so let's say you have a residual AHI of 7, 8, 9. In reality, it could be 7, 8, 9, or it could be 22, 29. You would not know it until you look at the actual data.
Oh, wow, that different.
Yeah.
So,
but as you go higher, it's actually much more accurate. So the overt stuff everybody picks up. It's more the subtler things which are very deviated.
The single digit AHI, like you mentioned. Okay. Well, Tavi, Imran, is this what your paper said as well?
Let me just give credit to Dr. Iftikhar, to Imran, that he had this initial idea. And of course, we all had this type of clinical experience where you're looking at a patient's entire picture, you're looking at the download, and sometimes it makes sense, sometimes it doesn't make sense. And you start, looking at the waveforms and you start looking a little bit more into detail. So Imran had this great idea that we probably should be scanning the literature and see what's the level of trust that we have accumulated in the literature, in the body of knowledge we have in the field. And we knew already that there is a huge heterogeneity in the way the CPAP manufacturers define respiratory events. So how do they come up with the so-called AHI? And maybe I should say up front, it probably should be called REI.
I wondered.
We're not looking at the total sleep time, but it's the total recording or monitoring time. But we also have so many other sources of variability, right? We have sources of variability related to night to night. We have, sleep stages, positional stages, and the way we actually change criteria for defining AHI on a polysomnography. So with all of those and having the, kind of anecdotal experiences, the bedside and clinic, that this is not always maybe reliable, we embarked on this review of the literature and meta-analysis. And I'll let Imran explain a little bit more about the methodology we employed.
Sure. Thank you, Tavi, and thank you, Seema, for inviting me to this podcast and for your interest in our meta-analysis. Second reason why we're having this discussion is because most of us in the sleep medicine field, patients included, have some doubts about the accuracy of the AHI reported by the CPAP machines. It's not inconceivable why that would be the case. I mean, to start with, your CPAP is not looking at your brain, in the sense it cannot score hypopneas based on arousals. This leads one to think that CPAP automated event detection algorithms that they have are underestimating the AHI. And also, like Tavi said, in the PSGs, the number of events are reported in relation to the total sleep time, whereas with the PAP devices, they're recording and storing the data over the total recording time. So again, another reason for discordance between AHI flow, AHI from CPAP, and the AHI we're getting from PSGs. And that leads one to think again that this could be another reason why PAP devices could underestimate their residual AHI. I'll say that some others would argue that that in certain situations you can actually see just the opposite, where the AHI from CPAP is actually overestimating the AHI. And there are some studies where they found a slight overestimation of AHI from CPAP, and I'll get into that in a few minutes. But as for the meta-analysis, we were primarily interested in understanding the accuracy of AHI flow from CPAP, the residual AHI that's detected by the built-in detection algorithms from the different CPAP machines. And the reason why we were interested specifically in accuracy was because if you look at the literature, several studies have shown that the CPAP reported AHI or AHI flow quote unquote correlates well with AHI determined from simultaneously conducted PSGs. These studies on the one hand report good correlation, but on the other hand show variable ranges of limits of agreement when they are looking at that, the blind Altman analysis, which is a way of looking at agreement, a graphical method that compares two measurement techniques or the sets of data that you get from two measurement techniques or devices against what's considered the gold standard, or in some cases the average of the two. So coming back to the correlation, you can have good correlation between two measuring devices, one that's being tested and the other one that's gold standard, but you may not have good accuracy or precision with the testing device. In this case, the CPAP AEDs, the CPAP determined AHI flow, and that really formed the basis for this meta-analysis. And so, specifically in this meta-analysis, we looked at the data from studies where study participants underwent sleep studies with CPAP, and the studies reported Bland-Altman analysis plots for data on agreement between AHI from PSG and AHI flow from CPAP. AHI from the PSGs was based on manual scoring of the airflow data that was coming from the nasal masks used in the sleep studies, and the AHI flow was from the CPAP's own algorithms that they were using to report AHIs. So from the pooled data that we got from this meta-analysis, the pooled data from the Bland-Altman analysis plots, we did find discordance, some discordance between CPAP flow AHI and the PSG determined AHI. But for the interpretation of Bland-Altman analysis plots, there really needs to be an already agreed upon cutoff of the mean bias of agreement for anything, in this case AHI, as to what constitutes a clinically significant mean bias or discordance. In this case, with CPAP, CPAP's event detection algorithms, because there is no such agreed upon mean bias or discordance, at least none that I could find in the literature, I decided to look at percentage errors for CPAP's event detection algorithm for AHI. And percentage error is something that's used in many different fields, not just in medicine. It's basically, it is the difference between the estimated value and the actual value in comparison to the actual value and then expressed as a percentage. So in our meta-analysis, the way we calculated percentage error was looking at the Bland-Altman analysis plots. We looked at the difference between the upper limit of agreement minus the bias, the mean bias, and divided that by the mean residual AHI that we were getting from PSG, if we assume that PSG is the gold standard. And then we reported that as a percentage. And so the pooled percentage error that we got from 4 studies where ResMed was used, it was 73%. And it was 59% for Respironics from 4 studies that we looked at. There was only one study on Fish and Paykel that reported Bland-Altman analysis plot, and the percentage error was 112% on that.
Wow.
So this is one approach to look at accuracy or discordance.
Okay.
Another approach would be like what Dr. Thomas and his colleagues did in their studies, where they, and correct me if I'm wrong, Dr. Thomas, where they think they basically manually scored the waveforms data from Respironics CPAP machines, and I think they found that their AHIs were higher than the CPAP reported AHI. I will say also that just the opposite of this, of what Dr. Thomas and colleagues found in their paper, in their studies, just the opposite of that was seen in a couple other studies where they looked at the ResMed waveform, and then when that was manually scored, where it was on the lower side. But like Tavi said and Dr. Thomas said, there's so much heterogeneity. The data is like all over the place. And I could go into more details on the scoring criteria used by the different CPAP manufacturers, but mindful of the time of our esteemed speakers here in this podcast, I will give them some time. But later on in the discussion, I'll be happy to go over the what is generally believed to be the algorithms used by ResMed and Respironics, the scoring criteria.
So can you bottom line it for me, please? Is the residual AHI reliable?
I'm not sure about reliable. For sure, it is not accurate for the reasons that I mentioned to you. And so, I mean, if the residual AHI coming from CPAP is high, then obviously it is high. I mean, and Dr. Thomas, as he already mentioned, that if it's low, that is, and you're still having some doubts about the data, that you could look at the waveforms and stuff. But I will say that our meta-analysis was a statistical exercise to look at to answer the basic question of whether or not it is accurate and how much discordance there is. And we did see some discordance, like I said, and I'll be happy to go over some on my thoughts on these scoring algorithms that the devices use.
So let's take a short break, and when we come back, we'll talk more about the reliability of the residual AHI on a PAP download. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apnea Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apnea Healthcare. Discover more about our innovative sleep program online today at apnea.com.
Welcome back to Talking Sleep. We're talking about sleep apnea management strategies using the residual AHI and waveforms captured by PAP devices. So what I'm hearing from all of you is that if the residual AHI is high, we know there's a problem, and we have faith in that measurement. But then if it's lower, we may not. Is that a fair way of saying it?
That's fair. The threshold of high is not very clear, but once it goes to double digits, and usually patients are symptomatic. You will occasionally have a patient who has merely high numbers, but they feel fine. And perhaps, they were just very severe and now they're so much better. They're quite happy where they are. I do worry a bit about patients who have, say, cardiovascular disease, atrial fibrillation, stroke, and so on. Respiratory fluctuations almost always drag along hemodynamics. And, you worry about blood pressure non-dipping during sleep and such. There's no data yet showing that someone who has high residual AHI has, say, non-dipping during sleep. That'll be a really cool study to do.
So stay tuned.
It hasn't happened. We are planning to do it, but we don't have it yet. Double digits is a problem. If it's less than 5, patients feeling well, I'll leave it be.
Okay.
We're not trying to eliminate every single respiratory fluctuation, right? That's not normal breathing anyway. The problem is really when the detected AHI is between 5 and double digits. If the patient is low risk, feeling well, maybe I'll do an overnight oximetry and stop at that, just to be sure. But otherwise, certainly, as a habit, because my patient panel is generally pretty complicated, I just look at the waveforms as a habit. Some of that is wasted time, I agree, but it's just a habit now.
So I'm curious, if you have a patient then that has unstable breathing, you've looked at the waveforms and you see this instability, what do you do? Like, how does that change your management?
There are many reasons for instability. Leak is public enemy number one. So if there is high leak or fluctuating leak, you want to take care of that. Body positioning does help for any given, disease, setting, pressure, etc. Breathing is simply better when you're not flat on your back. And then you have sleep fragmentation. If it's excessive, can cause fluctuating, unstable breathing, and high loop gain. How you may characterize it, whether it is classic central apneas, which are not that common on PAP devices, or just unstable breathing. Even pure periodic breathing is not so common on therapy. More often you just see respiration devoid of the stability which you would like to see. So you have unstable breathing. And most targetable is leak. Next would be loop gain. And the hardest is sleep quality. I mean, you can, provide some sleep restriction, things of that kind, but it's short of using a sedative. If a person is not sleeping well, you really can't enable stable breathing unless they're able to sleep well. Meaning, if they're persistently fragmented, it's really hard, along with sleep apnea. Commissar is an example. If you have really fragmented sleep, arousals, wake after sleep onset is up, and so on. And there also is apnea. That's particularly difficult to get a lot of stable breathing. And you may have to trade off and accept, okay, maybe I'll get 70, 80% stable breathing and live with that.
So, you've mentioned loop gain a few times. And so it kind of reminds me of a conversation we had with Dr. Danny Eckert and the PALM score. And so you're using the detailed download data then to infer or assess what your patient's loop gain is. Is that right?
Expressed high loop gain, basically.
Okay.
So once you support the airway, the collapsibility is no longer an issue, would become a minor issue. So you're left with arousals and you're left with loop gain. And the arousals, the best thing you can do is to make sure other obvious things like, say, anxiety disorder is treated. But otherwise, it's a decision tree whether you would add on, say, something like zolpidem as an example. And then you worry about long-term use of these things and such. But high loop gain can be targeted by estazolamide, non-supine positioning, even adding oxygen. In my center, we use dead space along with CPAP. But estazolamide is very easy to use. Tiny doses needed when you use it with CPAP. But you have to be confident that it's the loop gain part. So you have to be able to recognize periodic breathing, in this format where it's superimposed on a basic airflow pattern. It doesn't look as sweet as what you may see on a PSG, as an example.
Huh. So then would you bring them back in for PSG? Or do you base it on that detailed information you get on their download?
It's hard to get PSGs. And in some ways, the pandemic forced us to rely more on our visual confidence, if I may use that phrase. So these days, if there's really a high residual AHI, patient's quite symptomatic, there's overt periodic breathing, unstable breathing, we try to get them back to the lab.
Okay.
But if they are medically well, they're just young people, probably genetic high loop gain, we just empirically use low-dose estazolamide, like 125 milligrams. And we look at the waveforms again. And if there is stability, the patient feels better, we just stop at that. Otherwise, we try to get them to the lab.
So when you start then acetazolamide, do you do blood work first? How do you follow them? I mean, what is involved in that?
When I first started using estazolamide, I would do things like blood gas. I stopped doing all that. We do the renal. Yeah, it was out of control. So I was too afraid, I guess. But with time comes hope, confidence, and not recklessness. But we do renal functions, check the bicarb and such. We do ask about kidney stones. There is a non-zero risk, regardless of the dose of estazolamide you use. Over the long term, some patients will develop kidney stones. I have nearly 500 patients on estazolamide, and 3 of them have developed de novo stones. So it's very rare at those tiny doses of, say, 125 milligrams. Similarly, the diuretic effect is quite minor. Occasional person will be sensitive. The tingling numbness of the fingers, which is reliably present when you exceed 500 milligrams, is quite rare at 125. Over the years, I have lowered the dose I've been using. I would start at much higher, like 500 twice a day, and then became 500 once a day, then 250. Now, 125 seems to cut it. So when you're using it with PAP, you don't need much.
Okay. Oh, good to know. So Imran, you mentioned the different brands and how they determine a residual AHI. So if we look at ResMed, how do they figure that out versus Philips versus Fisher-Paykel?
Yeah, sure. So these are proprietary algorithms that they use that are reported in some of the studies, but it's generally believed that Respironics uses the weighted, it uses the weighted peak flow signals, and the ResMed devices use what they call the root mean square ventilation signals to detect obstructive events. So I'll start with ResMed. ResMed CPAPs score in apnea when the 2-second moving average root mean square ventilation, which is based on an inbuilt pneumatograph when it falls below 25% of the long-term ventilation for 10 seconds. That's the ResMed apnea. Respironics scores an apnea when it establishes a moving window of 3 to 4 minutes of ventilation, and the flow has decreased by more than 80% for at least 10 seconds. Hypopneas by ResMed CPAP machines are scored if the 12-second moving average root mean square ventilation falls below 50% of the long-term ventilation. And the hypopneas by Respironics are scored when the flow has decreased by 40 to 80% for at least 10 seconds. This is based off of the review of literature that I did when I was doing the meta-analysis, and I looked at the methods of all these studies, and this is how most of these studies reported in terms of how the events were scored. The key point here, I think, is that even though ASM scoring criteria for scoring respiratory events for sleep studies have evolved over time, those used in the algorithms for CPAP for ResMed and Respironics have not, even as newer CPAP models have been released into the market.
Is that because we rely on the saturation metric and we don't get that with CPAPs, or why do you think that is?
I don't know. I think if you look at the old studies and compare that with the studies that have just recently published on this topic, it is exactly the same scoring criteria by ResMed and Respironics. They really haven't changed at all. I don't know why. I'm not sure if it's because of this saturation, because the CPAP machines can't record oxygen saturation or arousals that are needed for scoring hypopneas. I'm not sure.
Yeah, I think Imran, you mentioned these are proprietary algorithms, and what I think they did was trying to fit specific models and specific thresholds for ventilation or tidal volume reduction based on their technology against all the other signals that we collect with polysomnography, such as pulse oximetry, and then of course the arousals. And they found relatively good correlation probably with these specific moving averages and thresholds. Although the trade-off is quite clear, if you have a 3 to 4 minute moving average versus a 2-second moving average, you're going to expect that you're going to have some dampening in the some of the events. But you're absolutely right. We changed the criteria for how we define apneas and especially hypopneas over time, at least 3 times. And those cutoffs have changed with those specific criteria, yet the manufacturers of CPAP devices have not changed their algorithms. Sorry, Dr. Thomas, you wanted to say something too.
Yeah, so I've been, whenever I get the chance, anyway, I've been pushing Philips and Respironics to flip the idea, to estimate stable breathing instead. So we know what's good instead of fighting over what's the threshold for what is not good. How about giving us also the amount of stable breathing? That helps us put it into context. Now, obviously, algorithms are proprietary and so on, but it'll be nice if there was some, meeting of minds of industry and academia and the ASM, and come up with agreed upon criteria for what should or should not be the minimum estimate to come up with hypopnea and apnea. But estimating stable breathing would be quite useful. I'm sure it's mathematically possible.
That's a really interesting concept, that instead of focusing on what's wrong, you focus on what percentage of the night is fine.
It's good, yeah.
And I think the other derivative of what you said earlier, Dr. Thomas, is that sometimes it's a big trade-off between what information, what data becomes available and what is shut off. And now we live in an era of big data, big capabilities, cloud-based systems where you probably don't have to compromise and use some of the information that is available. And I think uniting the industry with the academia in an effort like this would be very useful.
And that theme comes up almost regardless of what we're talking about, doesn't it? Whether we're talking about consumer-facing sleep technology or we're talking about, new metrics like ORP or whatever that is that we kind of want this meeting of the minds where industry and clinicians and academia, and research all come together to make a decision that we think will be hopefully clinically useful.
Absolutely.
2025 marks the 50th anniversary of the AASM. We will hear from leaders in the field as they reflect upon the influence of sleep medicine and the AASM on their careers. Here's Dr. Puleo remembering Dr. Dement.
He is an inspirational person. Whenever I heard Bill Dement speak, I always felt I wasn't doing enough work. No matter what I was doing, I always felt I had to do more. I remember the first time I got to write a paper with Bill Dement. I was a junior attending, and he asked me to write a paper on insomnia, and I wanted to show everything I knew about insomnia, and I poured everything I had into that paper, that draft about everything I knew how to take care of a patient with insomnia. And he sent it back and rejected me and says, "You wrote how to take care of a patient with insomnia. You did not explain how to take care of a population of insomniacs." So he raised my eyes. He raised my vision. And from that sense, it comes on to being involved in the ASM. How can you not be involved in the ASM if you're part of sleep and you're working with Bill Dement and Christian Gimeno like I was? Bill Dement was the founding president for 12 years. And he believed in what we were doing. So that's how it just naturally, part of him part of the ASM is because as individuals, you can only do so much, but collectively we can do so much more. And the ASM gives us the opportunity to do this.
And now back to our conversation. So I'm kind of stuck on something around that you said earlier. You talked about hand scoring the waveforms versus the PAP scoring. So now I think I understand better the moving window and things like that. But how different is it if you hand score the waveforms versus relying on the PAP scored events?
I think Dr. Thomas could probably elaborate on this a little bit more, because I think his studies were looking at the hand scoring of the waveform data versus the AHI that was reported from CPAP. All the studies that I looked at, these studies were basically patients came in, had sleep studies done in the sleep lab, and the ventilation signal, the flow signal, was actually derived from the CPAP mask, and that's what they hand scored, and then they compared that with the CPAP reported AHI.
Yeah, so we used the Philips system because it has waveforms. We printed out hundreds of pages of waveforms, and using marker pens, we scored using a visual 30% reduction, just like we would score a PSD. So it was as close to scoring a PSD as one could get using this tedious way. And then we counted all the events per line and added it up. It was pretty old-fashioned, labor of love type of thing, but it's pretty accurate in terms of we didn't miss anything. We may have overscored slightly, but we definitely didn't miss anything. And we could also, tag stable breathing, which was, what is not unstable was stable.
And what did you find?
The devices missed. At the lower end, the devices, I think it was 3 times miss. As you go higher and higher, it converges. And once you go into double digits, the what is not convergent is not really clinically relevant. Like, it's plenty. Whether you're 50% unstable breathing versus 45 or 40 doesn't really matter. It's just not working well. It's similarly, if you look at something like, say, continuous glucose monitoring, once your average goes over about 160, 170, it's just too high.
Okay. That's fair. That's
200, 170, 250, it's too high.
That's a good analogy,
You can make the medical decision. You don't have to worry about. But there's a big difference whether the average is 90 versus 130. That's a place where you kind of do make clinical decisions. So at the lower end is where I think perhaps tagging stable breathing rather than fighting over what's apnea, what's hypopnea could be just practically useful.
Well, it's interesting that you say that, because on the Philips, they would have that periodic breathing or Cheyne-Stokes that it would tag. and it would give you a percentage. And I would sometimes bring those people back to the lab, and I'm not sure that I always found the same thing that was picked up on the download.
So the Phillips periodic breathing is interesting. The algorithm is actually quite sensitive. It really picks up even a whiff of periodic breathing if it is long cycles. So the start to finish needs to be about 50 to 60 seconds, like what you may see with heart failure. It picks it up well and may even overestimate it. But if there's short cycles where good heart function, etc., now you're cycling at 25 to 40 second range, it often misses it because its algorithm, it won't tag it as periodic breathing. It may tag it as hypopneas, but won't tag it as periodic breathing because the algorithm is rigid.
So that's helpful to know so that you can, better know how to apply, those thoughts when you see that information,
Right.
So that's helpful. So other than acetazolamide, is there anything else you do when you have a patient that has unstable breathing? Other than, you said acetazolamide, maybe some zolpidem. Anything else?
Well, drug-wise, the class effect, zonisamide, and if Sultam ever becomes available in the US, we could use that too. But buspirone, there's one study in heart failure and at least one study in spinal cord, high spinal cord injury and central sleep apnea. Now, both those physiologies are kind of quite different. But buspirone was beneficial. So I have about a dozen patients now on buspirone. We test it out in the sleep lab. We have the patients come back on buspirone, or we give buspirone during the study, 15 milligrams, and it really seems to make a difference. Acetazolamide is better. It's the best if you can use it. Very interestingly, a tiny subset of patients on acetazolamide, they become hypersomnic. And you go back and look at the old published data on use of acetazolamide in glaucoma, and look at the tables of side effects. There you see severe fatigue, pre-dating clinical sleep medicine. So they become totally hypersomnic, and then you stop it and boom, they come back to normal.
Magic.
So it's very rare, but it occurs almost instantly, like, within the first few days, and it doesn't go away. You have to stop the drug. I've not seen that with zonisamide yet, but with acetazolamide, I've definitely seen that. But I've used much more acetazolamide than zonisamide. Oxygen is beneficial. It doesn't work for everybody. And most of the time, the patient ends up needing to pay for it. So it really has to do well. I mean, the patient has to do really well on it, feel the difference for them to, pay $70 to $100 a month or to buy an oxygen concentrator. Once you're on PAP, you don't desaturate much. So, Medicare, etc., won't cover
that's
oxygen.
fair. That's fair.
And then in our center, we use a non-vented mask configuration. Of course, there's a vent. We put an exhalation port, but that stabilizes CO2 fluctuations and allows us to better stabilize. So it becomes like a buffer, a good shock absorber for CO2 and helps stabilize breathing. Of course, we would evaluate an adaptive ventilator in the sleep lab where we can also use these various adjuncts. One caution about adaptive ventilator waveforms. Well, AHI, it's even more inaccurate than CPAP. And the reason is they use the tidal volume signal. I think it's a 50% reduction in tidal volume estimated. But the tidal volume is the combination of the patient and the algorithm. The algorithm is trying to noise cancel you, sort of. It's trying to anti-cyclic fluctuations in pressure so that you can have ongoing periodic breathing, and the device can keep fighting the periodic breathing, giving you a net tidal volume, which is sort of reasonable or under detection threshold, but it comes to the cost of the machine going back and forth and causing arousals and bad sleep quality.
Sure. Okay.
So you have to look at the pressure waveforms if you're using an ASV device. I don't believe the AHI. Of course, the AHI is high. I always believe it. But if it's on the lower side, I like to really view the waveforms.
I agree. And there is the issue of mask leaks. I typically tell our fellows in the clinics, do not necessarily trust the low residual AHI, flow-based AHI. If you have significant mask leaks, you have to fix that first. The other issue that it wasn't necessarily part of our meta-analysis is the auto-adjustable PAP machines versus fixed prescriptions. You go back in time and find that we had multiple in silico studies looking at the different auto-adjustable machine algorithms and find that some of them are more sensitive than others, some of them are too late. So you have to consider that also in the modality that you are treating the patient with.
That's a really good point. I'm curious too, is this over limited to people on PAP therapy, or do you see the same sort of thing with like Inspire?
Residual apnea is a problem with oral appliances, post-surgery, post-weight loss, post-everything. And the basic approach is similar. You try to endotype as much as you can. Obviously, we don't worry about leak with these other therapies. But high loop gain, there's a number of publications now showing that if loop gain is overtly high, you're likely to have residual apnea, on any anti-obstructive therapy. Then you got to decide, what is clinically meaningful versus not, and what's bothering the patient versus not. If you look at the Inspire data, published data and otherwise, residual apnea is common, but that's not surprising. This is a salvage treatment. Now, you're talking about someone who's failed CPAP.
Yep.
So they're going to have mixed physiology commonly enough. The question is not whether Inspire can normalize your breathing, but is it providing useful benefit for the patient? And often does. But to optimize, body position is important. Sometimes we add oxygen. We can use estazolamide. About 30% of my Inspire patients here, maybe a little bit more, is on low-dose estazolamide, about 10% out of supplemental oxygen. Just had to be fair to the patient and tell them that, okay, this is going to help your upper airway, but there may still be, more work to do, rather than signing off saying that Inspire done, checkbox, you're okay.
That's higher than I would have anticipated. 30% on acetazolamide? Wow. Okay. Yeah. Okay, good to know. So, do you each have a key takeaway for us? Tavi, we'll start with you.
Sure. I think there are plenty of takeaways. We're dealing with them clinically all the time. I would focus on we need better standards for reporting, better metrics for diagnosis and severity stratification, more transparency in the new sleep technologies, and maybe iterative processes in the field when we implement use of different technologies, and then how do we adjust over time our diagnostic approaches and therapeutic approaches. So I'll stop at that, since this is kind of a big picture, 30,000 feet type of takeaway.
Imran, how about you?
Yeah, so I agree with Tavi. The key takeaway is that, and this is really a message for the manufacturers of the CPAP machines, that there really needs to be a standardization of the scoring criteria for scoring respiratory events. And second takeaway is, as far as my meta-analysis is concerned, is that one cannot really be certain about the accuracy of the AHI flow detected from CPAPs. Yes.
How about you, Dr. Thomas?
Just use clinical common sense. I guess, if the data matches the patient, believe it. If there's a mismatch, dig deeper and then react to what you see. This is probably true for any technology, no different than this. But there really needs to be, as all of us are saying the same thing, the ASM needs to get together with the manufacturers, set up a committee, a program where there's just much more interaction so that each can inform the other. We can't tell them what to do, but we can certainly tell them what we think is the right thing to do.
Yeah, Tavi chaired a session at APSS last year where it was a group of industry people and some sleep people, and the industry people had supplied specific questions, and then Tavi was the chair, and he sort of moderated discussion between industry and clinicians, and I thought that was really effective. Tavi, you did a great job.
Oh, thank you. And that was probably my fourth one in that one of the common themes is on that line, which is they may need some guidance and for us to set standards and aspirations. And we also need to be on our side, see what's relevant clinically for hard outcomes, and how do we make our field progress over time.
Yes, a quick comment. We have to be conscious that every formal change of a medical software needs FDA approval, and there's
Right.
a cost to this. We just can't say, "Hey, why don't you try that? Why don't you try this?" No, we can't do that.
Yeah, that's fair.
absolutely.
It's too expensive. We have to be quite,
Pragmatic.
careful
Yeah.
and thoughtful about what we may ask industry to do.
Yeah, that's a very fair point. Well, thank you all for joining us today and taking us through some of these patient management considerations when we review a PAP download, and for helping us to glean more information on how this metric is determined.
Thank you. This was a great session.
Thanks for inviting us. This was a great discussion.
Yeah, thank you. Thank you, Seema.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.